So this week we are covering esophageal disorders. As a speech therapist, there's nothing you can really do for the treatment of esophageal disorders, but you do need to be able to recognize them when you have a patient that has one, and you need to be able to discuss them intelligently. So let's start with structural disorders of the esophagus. A lot of these are categorized as esophageal stenosis. And essentially what this is damage of the linings of the esophagus due to stomach acid getting past the LES into the esophagus, damaging the linings of the esophagus, creating some scar tissue within there. The tissue can manifest as what are called rings or webs, but it can also just be a general narrowing of the esophagus as well. And also, if there's like a tumor in the thorax or in the abdomen that is pushing on the esophagus, obviously that can create an obstacle for the bolus that is descending through the esophagus. If you have an esophageal stenosis, it is those more solid, dry boluses that will be more difficult to get down versus the softer food, the more wet food. It's going to pass through the stenosis, the narrowing of the esophagus, more easily. It is a fact that when a patient has an esophageal stenosis, oftentimes they will mistakenly identify the problem as being further superior. So you will have plenty of patients and they're telling you, they'll say, the food gets stuck. And you're saying, okay, where does it get stuck? Down here or up here? And they're going to motion, oftentimes they're going to motion, it gets stuck further up here. So they're feeling the blockage at a place where the blockage actually isn't occurring. So you have to be alert to that fact. So when a patient is saying that they have difficulty with food sticking here, there's a good chance that the UES is not opening appropriately and they're having trouble getting the food into the UES. But there's also the possibility that they have a lower problem of the esophagus. So esophageal stenosis, narrowing of the esophagus, esophageal rings or webs, they're treated medically. And usually the treatment is dilation. So the docs stick essentially a balloon down into the esophagus and inflate the balloon, which stretches the esophagus back out. This is the balloon, and they're about to inflate the balloon.
He's got a hernia, and it impairs passage a little bit. So this blue means I'm okay.
Just beyond that, you saw the right.
Right there?
Yes.
All right. Can we inflate him to... he's going to cough when we inflate this. Can we inflate him to 15, please? Okay. Suction his mouth out a little bit, please. We'll keep that for 30 seconds, and then we'll go up to 16 and a half. The balloon's not going to move that much. And inflate this balloon.
Got it? Going slow, Doc, okay?
We use the term esophageal ring when you have this band of tissue that forms at the lower end of the esophagus, closer to where the esophagus meets the stomach. The most common form of esophageal ring is called a Schatzki's ring. And here's a look at it right here. So that is a scoped view of the tissue ring, and you can see here that here's the stomach and here is a hiatal hernia, and above the hiatal hernia you have a Schatzki's ring. So they tend to be associated with the hiatal hernia, but most patients that do have the hiatal hernia don't necessarily have a Schatzki's ring. And they can be asymptomatic in some patients. Some patients, they can create a problem for the passage of food through the esophagus. We use the term esophageal web when we're talking about essentially the same thing, the formation of that ring/web of tissue, but we use the word web when we're talking about it more superiorly in the esophagus or even within the hypopharynx. And once these things form, they tend not to be progressive, so it's not like they're going to slowly form and seal off the esophagus entirely. It's typically they form and they just tend to create a mild problem for the patients that are experiencing them. So we're going to watch her swallow some barium, and you're going to see the esophageal web down here. You're going to see an obstruction below the UES. So you saw a glimpse of it right there. So let's go back and zero in on it. That's it. Right there. So if I pause it right there, you see, but also the bolus has been squeezed in half. So here's your esophageal web. And she is having to swallow 2 or 3 times to try to squeeze that bolus. See, it's just sitting right there. She's having to swallow multiple times to get that bolus down. And here's some more images of how rings and webs present. You can see it right here, and right there. There's a condition known as benign esophageal stricture, and this is generally associated with gastroesophageal reflux disease, or GERD, and this is the stomach contents, the stomach acid getting up into the esophagus, damaging the linings of the esophagus, scarring the lining of the esophagus, and creating inflammation and fibrosis and a narrowing of the esophagus. The primary symptom of benign stricture, the primary symptom of GERD as well, is heartburn. The difficulty pushing the food through the esophagus is going to increase over time, over years, and the heartburn and the symptoms associated with it will also increase. The treatment of benign stricture is essentially medical treatment for GERD. And the medical treatment for benign stricture is also going to include dilation of the esophagus, as it is with the rings and the webs. Esophagitis is what we're talking about, is inflammation and damage to the lining of the esophagus. And this can be due to acid reflux, but it could also commonly be associated with patients that are trying to dry swallow their pills and get a pill lodged in their throat and essentially don't realize that that pill is sitting in the esophagus as it melts, damaging the linings of the esophagus. And the esophagitis can lead to esophageal stricture, but it doesn't have to. And esophagitis is commonly associated with GERD and acid reflux, but just because you have GERD or acid reflux doesn't mean you have esophagitis. Esophagitis typically is pretty painful. I had someone complaining to me about it just yesterday. On the first slide of this lecture, I mentioned that a tumor in the thorax or the abdomen could be pushing on the esophagus, narrowing the esophagus, and that tumor could be benign, but it could also be malignant, meaning cancerous. Esophageal cancer is usually caused by smoking tobacco and drinking alcohol, or the combination of these two things. But there's also a condition known as Barrett's esophagus that puts the patient at increased risk of esophageal cancer. And what Barrett's esophagus is you have a patient that has gastroesophageal reflux disease. So the stomach contents are getting through the LES into the lower 1/3 of the esophagus and is damaging the tissue lining. But in Barrett's esophagus, the damaged muscle fibers of the lower esophagus, rather than healing appropriately, it heals to more resemble the pure soft muscle tissue of the intestines than sort of the mixed, soft, striated muscle tissue of the esophagus. Another esophageal disorder you need to be aware of is called esophageal diverticulum. And essentially, this is when a pouch is formed by increased pressure within the esophagus. So it pushes out a little pocket in the esophageal wall. And esophageal diverticulum, they're more rare than the diverticulum of the hypopharynx. That's where we usually see it. And the treatment for the presence of the diverticulum obviously is going to be usually surgical or maybe medical to try to control whatever is creating all that extra pressure. So here you can see an esophageal diverticulum. So here's your esophagus, and here's just a pocket there off of it. Now you can imagine how gross this is, and the things that just get in there and fester and set you up for an infection. That is the diverticulum. You can see there's just pieces of food just sitting in there. There is such a thing known as an esophageal motility disorder, and it's exactly what it sounds like. The peristalsis is somehow pathological. So perhaps the peristalsis, the squeezing, the force of the squeezing, meaning the amplitude of the squeezing, the amplitude of contraction can be too high, meaning it's squeezing too tight. It could be too low. It could be too prolonged to squeeze. The contractions of the peristalsis can be uncoordinated. So normally a nicely coordinated peristalsis, you're going to have squeezing the bolus down from top to bottom. But if it is contracting like this along the esophagus, then the bolus is just going to be pushed up and down and might be pushed back up into the pharynx, as well as might be pushed down into the stomach. So uncoordinated peristalsis is also a problem. You can also have abnormalities of the contraction of the LES. So maybe the LES is contracting too tight, in which case nothing gets through it. Maybe it's too loose, whereas stuff is not staying out of the esophagus. Maybe there's a lack of coordination between the esophagus and the LES. So these are all possible manifestation of esophageal motility disorders. So you're seeing the bolus being pushed up every once in a while. So that is a motility disorder. There's a condition known as achalasia, which is the LES is failing to relax appropriately, and it's failing to relax due to damage to the nervous system. And if the LES isn't relaxing appropriately, then the food isn't able to pass through it appropriately. So frequently results in backflow of undigested food after it is eaten. So the food is coming back up because it's not getting into the stomach. And here you see the bolus just sitting on top of the contracted LES. The treatment of achalasia is done through drugs to relax the sphincter, possibly balloon dilation of the sphincter, possibly Botox injections, and maybe a surgery. And I've already mentioned gastroesophageal reflux disease, or GERD. Many people have this, and it's within the realm of normal, but essentially what you're talking about is reflux of the stomach contents up into the esophagus, possibly out of the esophagus into the pharynx in severe cases. And as we've already said, the most frequent symptom is heartburn. One of the muscles of the lower pharyngeal constrictor is the cricopharynx muscle. And the cricopharynx muscle actually is one of the muscles of the upper esophageal sphincter. And if the cricopharyngeal muscle isn't relaxing appropriately, it's going to create what is known as the cricopharyngeal bar, and you can see it right here. The cricopharyngeal muscle is simply not relaxing appropriately, and it's creating this posterior prominence that reaches anteriorly, partially blocking the entryway into, partially blocking the creating an obstacle for the bolus to get into the UES. So these can be mild to severe. Some patients that have them may not even experience symptoms, but one of the problems they can create is that the patient has to swallow harder, has to swallow harder to get the bolus into the UES, and that is going to increase the amount of pressure within the pharynx and is going to put them at heightened risk for a diverticulum to appear in the hypopharynx. So here you see the cricopharyngeal bar and the bolus that's having to pass around it. And the treatment is medical. They will do a myotomy, which is they go in and they cut the muscle, or they could do Botox to it, or they could go in with a balloon and dilate it. And here you see the same patient after myotomy, and see that constriction, inappropriate constriction there is gone. A common diverticulum that as SLPs we have to know about is referred to as a Zenker's diverticulum, or the SLP might just refer to it as a Zenker's. And this is a diverticulum that forms on the posterior pharyngeal wall in the PE segment, so the upper part of the esophagus or in the hypopharynx. So it is same problems that you would expect with the other diverticulums. It's a bad thing to have just a pocket in your hypopharynx or your esophagus where food can collect and create problems. So after the patient swallows, usually you're going to see the parts of the bolus collect in the diverticulum. Or worst case scenario is that whatever material collects in the diverticulum is then pushed back into the pharynx after a swallow and aspirated. So you can see the diverticulum in this image here. It's barium that's just sitting here. And you can see that when the swallow is initiated and hyolaryngeal excursion begins, you can see that the diverticulum is elevated with the barium inside it. So it looks like the barium within the diverticulum is reaching up to interact with the descending bolus.